All right, cardiology, baby. Everybody's favorite, especially a second year medical student. Cardiology, for some reason, to a lot of people, they find it hard, but we're going to simplify it and we're going to talk about the whole foundation of what you need to understand, which is cardiac physiology. If you've got cardiac physiology down, then cardiac pathology, pharmacology, all that stuff starts to make sense. So let's dive right into this. The first thing that you really need to understand is autoregulation. What do I mean by autoregulation? Well, first of all, the definition is autoregulation is a physiological attempt to maintain constant blood flow despite changes in blood pressure or perfusion pressure. Now, why do we all, obviously, any second grader knows you have to have blood flow at all times, but let's think in a medical sense. Why do we need blood flow at all times or blood pressure? Well, remember, blood, hemoglobin, carries and binds oxygen. And what's important about oxygen? Oxygen, or the reason we breathe, is the final electron acceptor at complex 4, right? Remember from biochemistry? Yeah, everybody that says there's no biochemistry in medicine, well, they just don't know enough of it because it's everywhere. Oxygen is the final electron acceptor, and therefore it lets us make ATP to power every sodium, potassium, ATPase in the body for cells to use energy, and every other ATPase, such as the hydrogen, potassium ATPase in the stomach. So you have to have ATP at all times. And this is why we breathe, is to make ATP on a molecular physiological level. So, stated another way, autoregulation is the adjustment of blood flow through an organ in accordance with what? Its metabolic, see, back to biochemistry, its metabolic needs. Let me state that again. Autoregulation is the adjustment of blood flow through an organ in accordance with its metabolic metabolic need. All right. So the brain, what do we know about the three most important organs? The brain, the heart, the kidney, right? In that order. Brain, heart, kidney. Brain, heart, kidney. Well, carbon dioxide in the brain causes vasodilation and thus an increased perfusion, right? And in the heart, we know local metabolites such as carbon dioxide, nitric oxide, and adenosine cause vasodilation, right? And in the kidneys, you have what? Myogenic and tubuloglomerular feedback mechanisms, right? So what about the lungs? Remember, what does hypoxia do to the lungs? It causes pulmonary vasoconstriction, whereas everywhere else, oxygen is a dilator, right? But in the lungs, this is one of the really cool things in medicine. It is a vasoconstriction, right? So hypoxic pulmonary vasoconstriction. Remember that. Now, the lung is the only organ that responds to hypoxia by vasoconstricting. And this makes sense. Why does it make sense? Because it deflects pulmonary blood flow from hypoxic areas to where? Areas of better or good ventilation, right? That makes complete sense. This is a physiological mechanism to limit the VQ mismatch differences. All other organs respond to hypoxia how? Hypoxia. Well, I can't talk today. All other organs respond to hypoxia by doing vasodilation, which makes complete sense, right? In the lungs, when we don't have oxygen, we vasoconstrict and we get pulmonary blood from hypoxic areas to an area where we can breathe. We have good ventilation, right? Get away from the VQ mismatches. And in all other organs, you respond with no oxygen by vasodilating, get more blood to that area. It's not meeting its metabolic needs. Now, in skeletal muscles, local metabolites such as what cause vasodilation? Lactate, adenosine, and potassium. Potassium is the one that throws a lot of people, so remember that. All right, so moving right along. Now we're into the cardiac cycle. Now, the cardiac cycle, I mean, you can look at this graph and we can get really, don't let it overwhelm you. I remember learning this for the first time and I was like, good Lord, what is all this stuff? But just keep it simple, and I'm just going to give you what you need to know, and you can dive into it and learn all you want about it, but I'm just going to give you what's tested on. That's the most important thing that you got to get, the foundation. So the cardiac cycle, what you need to know is the process of cardiac filling and ejection. That's simple. Filling and ejection. It's just a pump. And is often visualized with electrocardiography or jugular venous pressure readings. And that's what we're going to see right here. Now, first of all, what is atrial systole? This is the activation of the atria, pumping atrial blood into where? Into both ventricles. Okay? Then we have something called isovolumetric ventricular contraction. Now, this happens when the ventricles contract before the aortic and pulmonary valves open, right? Isolated, volumetric, ventricular contraction. So you have to overcome the pressure in the pulmonary circuit and the systemic circuit, all right, in order for the aortic and pulmonary valves to open, because remember, they open up, whereas the tricuspid and the mitral valve open down, if we're looking at an anatomical perspective, that is, when I say up and down, but I think you get the picture. All right, so what about rapid ventricular ejection? This is the period of ventricular contraction after the aortic and pulmonary valves have opened, when the ventricles are ejecting blood into the pulmonic and systemic circulations, respectively. Okay, that's rapid ventricular ejection. Now, what about reduced ventricular ejection? All right, rapid ventricular ejection versus reduced ventricular ejection. Reduced ventricular ejection follows rapid ventricular ejection and results from decreased ventricular volume. Okay, this follows the good old Frank Starling equation. It follows the length-tension relationship, obviously described by Frank Starling. And this is where contraction strength is directly related to the load. Therefore, let's put that in another term. A decreased volume would translate into a decreased or an increased load. Obviously, it's directly related, so it would be a decreased load, right? Which means less contraction strength and a reduced ventricular ejection. So that's all that means. It's just a direct relationship. Don't make it harder than it is. And then we get into isovolumetric ventricular relaxation. Okay? Now, when does this begin? Isolated, volumetric, ventricular relaxation, diastole. It begins with the repolarization of the ventricles. All right? At which point the aortic and pulmonary valves do what? They close. When you repolarize the ventricle, right? Because first you have to depolarize before you can ever repolarize. Both of the aortic and the pulmonary valves are going to close, right? Because we're repolarizing. All right? Then that's followed by what? A rapid ventricular filling. All right, so and I could be going along here writing on the graph here, but I'm just kind of talking right now. I think you can follow along on the graph if you want. But a rapid ventricular filling happens when the atrial pressure equals the ventricular pressure. All right, I'll say it again. The rapid ventricular filling, all right, happens when the atrial pressure equals the ventricular pressure. It starts when the mitral and tricuspid valves open, okay? Then you have reduced ventricular filling, which is also known as diastasis. This is the longest part of the cardiac cycle, all right? Remember this part. Reduced ventricular filling, or diastasis, diastole, is the longest part of the cardiac cycle, okay? And it precedes atrial systole, all right? So we're talking about right here, and it precedes atrial systole. Okay? Now, let's talk about the heart sounds. First of all, heart sounds are never, ever, ever made by the opening of a valve. They are always, 100% of the time, made by the closing of something. All right? So the first heart sound, where are we at? The first heart sound is known as an S1. Okay? Let's get another picture here. All right. All right, so actually I'm going to go back to the other ones. I kind of like the other one better. All right, right here. Right there is your S1. Now, what makes the sound of an S1 or the first heart sound? It's the sound of the atrioventricular valves closing. It occurs, this is important, remember this, it occurs at the beginning of isovolumetric ventricular contraction, okay? Isovolumetric ventricular contraction. So, in other words, if we had a heart right here, you know, and the valves, they open down, right? It's a very simplistic way to think of this. Now, what has to happen here is when this ventricle depolarizes and contracts upward, right? These valves flop back and they shut. That's an easy way to think of that. Both of those valves will pop back and shut. And that's what gives you the sound of an S1 because you have isovolumetric contraction, ventricular contraction, right? And then before the aortic, run this way, and it opens up, you know, in the pulmonary circuit. Actually, I drew those backwards, but it doesn't matter. They open up into the pulmonic and systemic circuits. So they're not going to cause, you have to overcome those pressures in the pulmonary and systemic circuitry before the valves even open. And remember, you never get a heart sound by the opening of a valve. It's always the closing, right? So S1, bam, tricuspid and mitral valves close, and it occurs at the beginning or the end of isovolumetric ventricular contraction. I hope you said beginning. Very good. Now, let's talk about an S2. S2, the second heart sound, the lub-dub, 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 lub-dubs, S2. This is the sound of the aortic and pulmonic valves closing respectively. And normally the aortic valve you think closes before or after the pulmonic valve. Well, the aortic valve closes before the pulmonic valve. I wonder why. Higher pressure, higher resistance, bam, closes before the other one, the pulmonary valve, which is in a lower pressure, lower resistance, and compared to the systemic circuitry or the aortic valve. All right, and this may result in the splitting of the second heart sound, and that's what they mean by S2 splitting. Now, in medical school, I swear, I remember learning this and I could never really hear it, but it's, so it would be in the, it's not the lub dub, that's your S1, your S2, it's the lub dub dub, lub dub dub, lub dub dub, right? The lub dub dub, lub dub dub, lub dub dub. It's really close to each other, but all it is the systemic circuitry or circulation is under a much higher resistance than obviously the pulmonic circuit is, right? We don't want to pump a ton of blood at a crazy high resistance into our lungs, right? That would make no sense, but we need to shoot it out into the system because it's got to go from your head to your big toe, you know, so we have to be under a higher pressure and resistance in order to do that. That's why the left ventricle is always bigger and more hypertrophy than the right, respectively. Okay, so the aortic valve closes before the pulmonic valve because remember, the resistance in both circuits are pressing the valves down, right? Because right here, basically think of it like this. It's pressing the valve this way, back down, okay? And that results in the splitting of the second heart sound, and it's typically during when? Now, everything we've talked about, you're going to have to think here. Would it be during inspiration or expiration that you would hear the splitting? It would be typically during inspiration, and now tell me why. Going back to autoregulation and biochemistry, remember, oxygen is a pulmonary vasodilator, right? So if we're dilating the lungs and the pulmonary circuitry or the circulation, therefore, wouldn't the pulmonic valve close after the aortic? For sure, you're vasodilating, less pressure, less resistance, bam. it's going to close later than the aortic valve. So that's kind of where all this comes together, and it's really cool. All right, so we have two pathologic heart sounds. That would be the S3 and the S4. Now, the third heart sound, also known as the S3, results from blood sloshing against the ventricular walls during the middle third of diastole. All right, and that's what you see right here. During the middle third of diastole, we will hear an S3. All right, now basically think of this. Think of it this way. Let's see if I can figure out how to get a new sheet here. Yeah, new slide. There we go. All right, so think of it this way, and it'll be much more simple. Think of an S3, the third heart sound, as a volume problem. Think of an S4 as a resistance problem. And boy, I have to thank the man that taught me this, Dr. Francis, up at the. Anyway, if none of y'all have heard of the PASS program based out of Champaign, Illinois, in Chicago, man, I highly, highly, highly recommend Dr. Francis to you. He is the best medical educator in terms specifically of physiology and truly understanding physiology. Nobody even comes close. He's the best medical educator there is. So look that up if you haven't already. I'm sure most of you have, but the PASS program, PASS program, look it up. It is well worth your time of going. But as Dr. Francis would say, an S3 is a volume problem. The S4 is a resistance problem or pressure problem. All right. So the S3 is always going to come after the S2. So if we have an S1 here on a linear graph, and then we have an S2 right here, is where you would see the S3. All right. So remember, it is resulting from blood sloshing against the ventricular walls during the middle third diastole. Volume problem, okay? So anything that's too much vasodilation, like heart failure or anything like that, think of an S3. But when you think of an S4, that is usually due to a hypertrophic problem, hypertrophic cardiomyopathy for whatever reason. All right, the fourth heart sound is a low frequency, get this, diastolic sound. And it's always going to come before your S1. So think of this as if it were just a big circle here, okay, going this way. The S4 is going to come right before the S1. Da-doom, dum, da-doom, dum, da-doom, dum. Whereas an S3, lub-dub, dum, lub-dub, dum, lub-dub, dum, lub-dub, dum. S4, da-doom, dum, da-doom, dum, okay? It's a low frequency diastolic sound that occurs during the late. This is early, this is late, okay? During the late diastolic filling phase, and that's where they get the term the atrial kick. The S4 is actually when the two atria have to kick so hard to open the tricuspid and the mitral valve that they actually the walls hit together, and they call it an atrial kick, and it's due to so much pressure, okay, in both circuits. All right, and that's usually due to all the things that we will get into in pathology that cause you to have a hypertrophic heart, like high blood pressure would do it. Absolutely, you have too much pressure or too much resistance in the circuitry, and therefore we have to pump harder, and that's what causes atrial kicks. And it's the result that from the atrial kick filling a ventricle with a decreased, this is muy importante, decreased, and it's important, I say, because it's always in test questions. So you have to talk the language, and this stuff is really simple, but if you don't speak the language, I definitely can see how it'd be very complicated for you. All right, because usually when I learned this, an S4, you wouldn't think of that as a diastolic sound because we're talking about resistance and we're talking about pumping. You think contraction, you think systole. It's a low frequency diastolic sound occurring in the late diastolic filling phase. We get the atrial kick, and it's resulting from a ventricle with a decreased compliance. All right? Very important to understand that. Now, one more thing besides the volume and the resistance about these, the S3, the volume problem. There are two people when this may be normal. All right, let's get another sheet here. there are two people when the S3 is normal. Normal in children, and who else? Pregnant women. All right, that may be normal. In adults, it is associated with what? An increased filling pressure from a dilated ventricle, volume problem. And that's why it's considered pathological. Remember, I told you always hear it, usually heart failure due to too much vasodilation or too much dilation of the heart. That's when you see this. Now, the S4 can be normal in young children. I usually always thought of the S4 as always pathological, and usually that's going to be true, but it can be normal in young children. But if they're older than 20 years of age, it is not normal. So don't really worry in children, because you can see an S3 and an S4 can be non-pathological in children. Okay? Now, all right, let's talk about the diacritic notch. Let's go back to some pictures here. Now, right here is where the aortic valve is closing. You see that? They call that the diacritic notch. The diacritic notch, and this is in the aortic pressure curve. Obviously, that's what we're looking at. See right here, aortic pressure. Aortic pressure curve is where you see this at, and it's from the aortic pressure recoil against a closed aortic valve. The trough is where the aortic valve closed. Okay, so that's all that is. And here is a better picture of it. The diacritic notch right there. Right there you go. Okay, now we need to talk about the A, C, X, V, and Y. So we have something called the A wave, okay? Now the A wave is an increase in right atrial pressure during atrial contraction, also known as atrial systole, okay? Now what does that mean if the A wave is absent? An absent A wave, let me write this in there for you, because this is tested on for sure. Okay. An absent A wave. An absent A wave is characteristic of atrial fibrillation. So if you see an absent A wave, you think atrial fibrillation due to a lack of coordinated atrial contraction. Okay? Now, what if you see a giant or a large A wave? That indicates the right atrium is contracting against an increased resistance due to right ventricular filling. So a giant A wave may be seen with what? There's quite a few things can be seen with, but remember resistance. Just think resistance and it becomes very easy. But what you're going to be tested on is tricuspid stenosis. Now that's not the only thing you can see a large A wave with. How about right ventricular hypertrophy? You know, it's the same thing. All these words mean the same thing. How about pulmonary stenosis, right? Or how about pulmonary hypertension? How about not breathing as much oxygen? Remember, that's no oxygen, pulmonary vasoconstriction. How about a right atrial myxoma? That one I have seen tested on. But remember, these are all right. We're talking about the right side of the heart. Right atrial myxoma. I hope I'm saying that right. Myxoma, who cares? You get the point. Okay. Now, we also have something called a Cannon A wave. That's right, Cannon A wave. All right. Now, this is a large A wave with a sharp ascent and descent. And it's caused by the right atrium contracting against, you guessed it, a closed tricuspid valve, which most commonly occurs during junctional arrhythmias. So what's an example of a junctional arrhythmia? Big word there. That it would be like a complete heart block or a third degree heart block. Block, baby, lock down. Third degree complete heart block is when you need to think of a Canon A wave. And I don't think I put pictures in here of these, but I'll put them in here real quick for you. Actually, I'm not going to put the pictures in there. I think, you can listen to this in Google or something, these cardiac tracings, jugular tracings, and you can see all this, but I just want you to know what you're most likely to see on a test. All right, what about a C wave? But remember, you will need to recognize these and what they look like. So I would, suggest getting a picture and looking at that. A C wave is an increase in right atrial pressure. Again, right atrial pressure during right ventricular isovolumetric systole or contraction. And this is due to the bulging of the tricuspid valve into the right atrium. All right, so it's nothing more than an increase in pressure in right atrial pressure. Okay, now how about that good old X-rated wave? Actually, about rated. All right, and that's actually not the wave, but the X descent would be a better way to say it. So the X descent is a decrease in, you guessed it, right atrial pressure following the peak of the C wave due to what? Atrial relaxation. See, I told you this is not hard. So now here's where they can get a little tricky, so make sure you understand this. What if I told you that patient X has an absent X descent? What would that be? Well, I hope you said that would have to be tricuspid regurgitation. Regurg. All right. Now, what about if you have a rapid or a prominent X descent wave? This occurs in a couple things. This is muy importante, so make sure you get this because they love to test you on this. If you have a prominent or rapid X descent, that occurs in number one, and the one I would remember, cardiac tamponade. Cardiac tampon. Cardiac tamponade. Don't forget that. And obviously, number two would be constrictive pericarditis. Okay? Constrictive pericarditis. Now, constrictive pericarditis also has a prominent Y descent. But what would be different with cardiac tamponade? It has an absent Y descent. Now, we ain't even talked about the Y descent yet. We're going to get into that, but just that's how you can classify or differentiate between the two. So what about, let's get this new sheet here. What about the V wave? The V wave. This is an increase in, you guessed it, right atrial pressure during late ventricular systole or contraction due to right atrial filling against a closed tricuspid valve. So the peak of the V wave usually corresponds with or occurs just after what on the EKG? Occurs right after the T wave. And if you look at the EKG and you look at the whole cardiac cycle graph, it's a lot easier to see. But I don't want to write all over here because it would get kind of confusing. Just take it one step at a time. As I'm talking about these, the best thing I would do is print out the graph and look at it as I'm talking about it. I hope I'm not talking too fast, and it'll make much more sense to you. So what they're going to test you on is a large or a giant V, also known as a CV wave. Okay, that can occur due to also tricuspid regurg. Now, we just talked about what else can occur with tricuspid regurg. Remember the X wave descent, which can be seen in cardiac tamponade and constrictive pericarditis. All right, very good. Now, what if, actually, no, that's all I need. Yeah, that's good. Just remember that part. So what about the Y wave that I was talking about a second ago? The Y wave, or the Y descent, this is a decrease in right atrial pressure following the peak of the V wave. And this is due to, what would this be due to? The tricuspid valve opening. Very good. Very good. All right. Tricuspid valve opening. So, if we have an absent Y descent, what would that be due to? This is the one I would remember. Absent Y descent, you immediately think cardiac. That was supposed to be in red. Cardiac tamponade, okay? Absent Y descent, cardiac tamponade. What about if it's a slow Y descent? That one is due to tricuspid, you tell me, stenosis. It's hard to pop that sucker open. So it's taking longer to do that, right? We have to have more atrial contraction, therefore more resistance, more pressure, pop it open, let the blood get into the ventricle. Tricuspid stenosis results in a slow Y descent, okay? Now, what about if you have a rapid or prominent Y descent? So of all these I've talked about, these are the ones that they're going to test you on. And remember, this can occur and does occur in what I want you to remember. Number one, constrictive pericarditis. All right. Number two, severe right-sided heart failure. Now, what is the most common cause of severe right-sided heart failure? I hope you said left-sided heart failure. 95% of the time, or they'll say 90, but it's more like almost every single time, left-sided is going to cause right-sided heart failure. Why? Because it's a pump. It's a closed pump. If the left side's messed up, then it's going to screw up the right? Because we have to pump from right to left. That's simple. All right, number three, tricuspid regurg. Tricuspid regurg. This is the large CV wave, sets the stage for a large Y descent. Okay? So, those are when you see a rapid Y descent. Constrictive pericarditis, severe right-sided heart failure, which is probably the one I'm going to test you on, or tricuspid regurgitation. All right? So, very good. You got through that just fine. Moving right on. The cardiac myocytes. The cardiac myocytes. All right. There's 3 points that differentiate cardiac myocytes from, you got it, skeletal muscle. All right. So we're talking about a nerve that's controlling a muscle here. Just remember always the basics first. So number one. All right. 3 points here. Cardiac muscle action potentials. Action potentials have a plateau. Okay? They have a plateau. We're going to talk about during the plateau, calcium and troponin and all that good stuff. Number two, cardiac nodule cells have something very cool. Automaticity. And they spontaneous. They're so spontaneous. They depolarize. Spontaneously depolarize. Okay, it's really cool. Now, number three, cardiac myocytes are electrically coupled by, you tell me. All right, think about it. Cardiac myocytes are electrically coupled by something known as gap junctions. You got it. These are low resistance paths between cells that allow for rapid, boom, rapid electrical spread and account for an electrical syncytium. Now, what does that mean? It's a bunch of big words. It means nothing to me. An electrical syncytium is critical. The heart has to contract as one unit, right? But the electrical activity of the heart, it has to get from top to bottom. So how and back to the front to repolarize, how does it all contract at once? Boom, boom. It's gap junctions is what allows that. Your card is so cool when you really understand it, man. It is very, very neat. So let's look at number one there. Cardiac muscle action potentials have a plateau. Now, to understand this, let's look at this picture right here. All right, so during the plateau, calcium conduction, not sodium, calcium conduction is increased, and calcium enters the cell from not extracellular fluid. So you get an inward calcium current. Yeah, all right, so that doesn't happen in other places. You get an inward calcium current. All right, but we all know in skeletal muscle, calcium is released when the cell depolarizes from the electrical activity, right? And then the whole thing goes to release calcium from the sarcoplasmic reticulum and it binds troponin. Not in the heart. Extracellular fluid, you get an inward calcium current. Now also a transient closing of the inward rectifier potassium channels. This is what allows the inward calcium current to be temporarily balanced by the outward potassium current. And that's due to the delayed rectifier potassium channels, which are still open. Remember that in all cells, potassium is the only ion that is half voltage regulated. It's not completely regulated, right? So let me repeat what I just said to make sure you get it. There's a transient closing of the inward rectifier potassium channels that allows the inward, this is what allows the inward calcium current to be temporarily balanced by an outward potassium current. And that's due to the delayed rectifier potassium channels, which are still open. That's beautiful, man. Then calcium entry triggers the release of even more calcium. So this is where it becomes like skeletal muscle, okay? That's what triggers the release of even more calcium from the sarcoplasmic reticulum. And this is when calcium, it's called a calcium-induced calcium release. Extracellular calcium, all done because of these potassium rectifier channels, right? Calcium extracellularly causes an induced intracellular calcium release. That's so cool. I had to read it like 10 times when I first learned it. I was like, wow, that's nuts. But as a result, calcium binds to what? Troponin C, not troponin I, troponin C, and tropomyosin is moved out of the way, allowing the actin-myosin binding. Now, the magnitude of old Frank Starling, the magnitude of the tension that develops is proportional to what? Intracellular calcium. That's why calcium is so important. All right, not only, I mean, it is critical, absolutely critical. All right, so if we look at these two tracings here, what is the difference in this one? We'll call him B. We'll call this guy A. Notice that B, where's B got to be coming from? You see this little upstroke here that's kind of constantly moving up this way? And this one here, he's at baseline, boy. See that? A's at baseline, so all of a sudden, bam, something happens, right? That's where this guy is depolarizing. And right here, slowly, this guy's depolarizing. So where would B, based on what we've said, have to come from? This comes from the SA and the AV nodes, right? Because they have automaticity, right? Automaticity. Where's A got to come from then? That's the action potential of the ventricle, okay? These cardiac myocytes or the ventricle, they have a different kind. The sodium channels right here, bam, they rush in, sodium right here, rush in, depolarizes your ventricle, then you see everything we were talking about, right? Back to baseline right here. But notice this guy, this is these rectifying potassium channels that always kind of give, it's what gives this the automaticity, right, in the SA and the AV node. And here's in correspondence with this one, this is what you see on the EKG in correspondence to the ventricle. So that's really neat stuff, man. But to better explain it, how are they going to test me on this? That's what you want to know. Well, this drawing is an idealized action potential. It's idealized action potentials of non-pacemaker and pacemaker cells. That's where we said AV and SA node versus the ventricle, right? One's a pacemaker, one's not. B, that's pacemaker. A, non-pacemaker. So an A, the action potential of a non-pacemaker cell is what we're illustrating here. Now there's 5 phases on the action potential. 0, 1, 2, 3, and 4. And that's what we're identifying here. Now the membrane potential during phase 4 is stable at approximately negative 90 millivolts. This whole scale right here in gray is in millivolts, right? The electrocardiogram of the EKG in the lower section of A is showing the relationship to the various phases of the action potential. Now the QRS complex corresponds to what phase of the action potential? Phase 0. That I've seen a lot of questions on. This corresponds get my green back to phase 0. Now the QRS, what is the QRS happening? Ventricular, right? Ventricular depolarization. Phase 0. QRS complex. Ventricles depolarizing. Bam, they fire. We went from negative 90 millivolts all the way up here above threshold to almost positive 20 millivolts, right? And that's done by what ion? Sodium rushing in, not calcium. The calcium rushing in extracellularly to trigger inward calcium is what governs and causes automaticity. But that's when we're talking about the SA and the AV node. And nobody really clarified that in medical school. So I was always very confused as to, hey, I thought calcium had to rush in to cause depolarization in the heart. Only the pacemaker cells. Only the pacemaker cells. Sodium, as a rule of thumb, sodium depolarizes every membrane in the body except in the heart, which is done by calcium. But in the heart, I'm not talking about the ventricular or the ventricular myocytes. I'm talking about the SA and the AV node. Okay? All right, very good. Now the T wave corresponds to what? Obviously, just look on the graph. The T wave right here corresponds to phase 3. Phase 3 of the action potential. Now, what's happening to as we start to repolarize here? Bam, we depolarize, stay constant. We start to repolarize down to threshold. What's going on right there? Well, potassium is leaking out, right? So is that cell becoming more positive or negative? Well, actually, we'll get into all that, but just know that it's becoming more negative, okay? So the QT interval approximates the action potential duration, all right? So the QT interval right here, that approximates, as you can see, the action potential duration. Now, as we look over here at B, the SA and the AV node, these are action potentials from a pacemaker cell. Now, the membrane gradually declines during which phase? Phase 4. The membrane potential gradually declines during phase 4. Now, let's look at the ventricle depolarization right here. I'll redraw this for you. Bam. Right? 0, 1, 2, 3, 4. All right. Now, the rapid depolarization of the ventricle cardiac myocytes is done due to, remember, voltage-gated fast sodium channels. Bam, right there's what we're talking about. Now, in this plateau right here, 1 and 2 happen. This is the plateau. It's a maintained depolarization due to the opening of voltage-gated slow calcium channels and the closing of some, remember I told you that only half of potassium channels are voltage regulated, closing of some potassium channels. So we get a fine balance right there. And that's what gives us the maintained depolarization. It's the opening of voltage-gated slow calcium channels and the closing of half of the potassium channels, right? And then right here we start to repolarize. So 0, depolarize sodium, fast sodium. 1 and 2, all right, 1 and 2, think calcium, slow calcium, closing of what you can close the potassium channels. And then on the repolarization, this is due to the opening of voltage-gated potassium channels and the closing of calcium channels. Okay, so that's literally all this is. All right, so let me better explain this. So this picture right here gives you a better explanation of kind of what's going on. So, all right, here's my millivolts. Millivolts right there. All right, so we're setting right here at resting potential of negative 90 millivolts, right? And what's keeping that there? You see this IK1? That is the inward rectifier. So in other words, that's an outward potassium current, okay? That's an outward potassium current. Now, yeah, that's right. Even I get this kind of backwards sometimes. But we also have the sodium calcium, what you see right here. That's the inward sodium and calcium current, right? Because back to cell physiology, right, and that's what we're talking about here, you can have a sodium calcium exchange. And that's why in the end of pathology, cells become more likely to depolarize, right? Because of that whole switch between these two. But anyways, so what happens, we are at rest here, phase 4 of the axis potential, bam, we depolarize, right? And that's the I of Na. That is phase 0. The I of Na, what is that? That's your fast inward sodium current. All right, and that takes us up and the cell fires. Then we get to phase 1. This is your transient outward potassium current. It's called the IPO, okay? That's in phase 1. It's transient for the T, outward potassium current. Then we get to phase 2 right here. Now there's a lot going on in phase 2. You have the I of calcium or the I of Ca. That is an inward, right? Inward calcium current. So calcium is coming in, right? Then you have the I of K, which is a delayed rectifier. Just think of it, it's nothing more than an outward potassium current. Then you have the I of K1, which is an inward rectifier, which basically it's an outward potassium current. If you ain't got it by now, trust me, this is where they test you on. Because one's a delayed rectifier, one's an inward rectifier, right? But you, with both of them, just know you have outward potassium current with I of K and I of K1, okay? But it's the I of K1 at phase 4 that keeps this sucker at rest. So the I of K is the only one that's different. It's a delayed rectifier, okay? And then you have the I of TO, which is your transient outward potassium current, okay? That's all happening at phase 2 to get your delayed depolarization, all right? So then we get to phase 3. What's happening in phase 3? You got your I of K, which is the delayed rectifier, in other words, outward potassium current. It's bringing me back down to, bringing me back down here to the resting membrane potential, right? Outward potassium current. If a positive charge goes out of a cell, is that cell more negative, more positive? More negative, right? So therefore, it's less likely to fire, less likely to depolarize. That's why we're coming back down here to threshold, right? So I always thought of anything below this line down here, less likely to fire. Up here, more likely to fire, right? That's simple. So another way to think of this is if you take off, it's much easier, I think, to see sometimes if you take all this junk off here and you just look at basically what's going on. Let me get all this erased for you and hopefully make a lot more sense. All right, so here we can see much better what's going on. Just, all right, potassium, sodium, and calcium playing a role here. Sodium only there to depolarize, as we talked about. potassium and calcium playing a role here. And then look here, potassium, potassium, potassium again, back to the same. All right, calcium and the sodium exchange. So I've seen so many explanations of this. I'm just trying to give you what's going to be tested on and try and make it as simple as I possibly can. And if you really want to know what's going on here, I'm telling you, watch the past program videos. He does an awesome job of explaining it. So hopefully you've got enough of the idea of what's going on. All right, so moving right along, cardiac output and pressure measurement. Very, very tested topic. Let's get this off here, actually. All right, your first equation that you have to know, cardiac output equals what? Stroke volume times heart rate, right? Stroke volume is a function of contractility and preload, all right? So we can use Fick's principle, which is cardiac output equals VO2, which is oxygen consumption in milliliters per minute, VO2 divided by the oxygen content of arterial blood minus the oxygen content of mixed venous blood, noted CV. All right, that's Fick's principle for cardiac output. It's talking about the oxygen consumption in milliliters per minute, which is your VO2. You always hear athletes talk about my VO2 max is blah, 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 blah. All right, divided by the oxygen content of arterial blood subtracted from the oxygen content of mixed venous blood. And then we get into the great equation of mean arterial pressure. This one is key to know. Equals cardiac output times total peripheral resistance. Okay? Now, technically, mean arterial pressure, technically I say, I'll write it in here for you, mean arterial pressure equals cardiac output times total peripheral resistance plus central venous pressure. That is the technical formula. But however, the central venous pressure is usually quite low compared to mean arterial pressure. So this can be approximated as mean arterial pressure equals cardiac output times total peripheral resistance. A lot of people, in medical school, I wasn't taught this about the CVP, but central venous pressure is what is right atrial pressure. Doesn't things always flow from a high pressure to a low pressure? So if you have central venous pressure, the preload coming back to the heart, if right atrial pressure is almost nothing under normal physiological conditions, then central venous pressure has to almost be nothing, right? Very good. Now, you all also probably seen this one right here. Mean arterial pressure equals diastolic pressure plus 1/3 pulse pressure, right? Or alternatively, you could say that mean arterial pressure is equivalent to 2/3 diastolic pressure plus 1/3 systolic pressure, right? So therefore, we get pulse pressure equals what? Systolic minus diastolic pressure. Now, pulse pressure is directly proportional to what? Now, think about this. Pulse pressure is directly proportional to what? Stroke volume. Okay? A higher stroke volume, such as in, give me a pathological condition. A higher stroke volume, how about aortic regurgitation, right? Absolutely. That will exhibit a high pulse pressure, like a high systolic and a low diastolic measurement, right? So aortic regurg is going to give you a higher pulse pressure because it's nothing more than systolic minus the diastolic pressure. Simple mathematics, right? It's directly proportional to stroke volume. Do not forget that. But these right here are the two that you absolutely have to know. Cardiac output equals stroke volume times heart rate. Mean arterial pressure equals cardiac output times total peripheral resistance. All right, very good. All right, I want to go back to the action potential here, the cardiac ventricle, and I want to talk about it a little bit more just to make sure that we got it, because I don't think I did a very good job of explaining it. If I was listening to this, I don't think I would have got it by the way I explained it, so I want to make sure you get it here. Now, action potentials in the ventricles, the atria, and the Purkinje fibers have 5 phases, right? So with that said, I thought I said before that there was some difference, right? I did, that's right. And the SA and the AV nodes, which have automaticity, which you see right here. Automaticity. If you ever see that tracing and you see this upward slope here, automaticity, you know that that is not a ventricle, an atria, or a Purkinje fiber. And how do you know that? Because you don't see 5 phases. 1, 2, 3, 4, 5. And you can tell just by looking at the tracing, right? All right, very good. Now, these cell types, the atria, the ventricles, the Purkinje fibers, have a resting potential of, what did we say? Negative 90 millivolts, right? The resting membrane potential is determined by the conductance of what? Potassium as it approaches the potassium equilibrium potential, right? So we have phase 0. This is the upstroke of the action potential. That's a fast voltage gated what? Sodium channel, right? Very good. Now, phase 1. This is the cell becoming more positive or more negative? Well, it's on a downward slope, more negative, right? So you know it's got to be talking about what? Repolarization. This is initial repolarization. This is the inactivation of voltage-gated sodium channels and the activation of voltage-gated potassium channels. Activation, right? Potassium is the greatest intracellular ion. If you activate the voltage-gated potassium channel, it's going to leave the cell. It's going to become more negative. So this makes sense. And it results in a transient repolarization that explains this small dip after phase 0 and before phase 2. Okay? A lot of people overlook that one, so don't overlook that one. Now, phase 2, this is your plateau that they talk about. That's your plateau. Now, this is your calcium. See, before phase 2, calcium, it's not been activated. All right, we're not talking about calcium until phase 2. This is the calcium influx to the L-type voltage gated calcium channel. And it's balanced by the potassium efflux. Anytime I talk about potassium, think efflux out of the cell. Potassium efflux through voltage-gated potassium channels. All right, you have a calcium-induced calcium release from the sarcoplasmic reticulum in phase 2. That, I promise you, will be tested. It is phase 2. Where you have a calcium-induced calcium release. And therefore, what do we get? Contraction. Bam. Contraction. The myocytes contract. Right? Very good. Hopefully this is making more sense. All right, very good. Now moving right along. Where are we at now? We're at phase 3. Phase 3 is the rapid. See how rapid that is? Phase 3 is the rapid repolarization. You get, calcium conductance decreases here due to the closure of voltage-gated calcium channels. Now, the potassium conductance through potassium channels obviously increases. It's leaving the cells become more negative. Guess what? That looks more negative to me. Absolutely. With a subsequent large outward potassium current that hyperpolarizes or repolarizes the membrane of the cell. All right, that's all phase 3 is about. And then we get to phase 4, the resting membrane potential, which we were at before we depolarized, right? This is an inward and outward currents are equal again. So now what are we going to talk about? We are going to move on to combining cardiac output and venous return curves. This is a huge testing point on the USMLE, and a lot of students unfortunately miss this, but it's very simple, which you're going to see right here. So what are we looking at? Well, just by looking at this on the y-axis and the x-axis, you have cardiac output right here, or venous return, right, in liters per minute on the y-axis. Now on the x-axis, you have right atrial pressure, millimeters of mercury, or end diastolic volume, EDV. All right, so always know what the graph is talking about first, because they like to flip this, twist it, and do all kinds of weird things with it. But to get started, equilibrium, or steady state point, another way of saying equilibrium, is the point at which two curves intersect. So in other words, what does that mean for our terminology? Cardiac output equals venous return. Okay, that's all you need to know. Cardiac output right here equals venous return. Okay, that is equilibrium or steady state. All right, so we have a mean systemic pressure, which you can see right there. Mean systemic pressure is the point at which the vascular function, or venous return, curve intersects the x-axis. All right, this is equal to what? Right atrial pressure. That's all mean systemic pressure is. A lot of times they don't include this right here in the graph. They'll just give you the cardiac output and the right atrial pressure, or end diastolic volume. Okay, so make sure that you remember that. The mean systemic pressure is the point at which the vascular function curve intersects the x-axis and is equal to right atrial pressure. Now what about the venous return curve right here? Sorry if this seems a little elementary, but I want to go over this because I'm telling you, a lot of people miss this. But the venous return curve describes the relationship between blood flow in the vascular system and right atrial pressure. That's all it is. Okay, so with that being that simple, how do a lot of people miss this? That's what we're going to get into right now. So mean systemic pressure is increased by what? Well, an increased blood volume, or number two, it's another way to do it, a decreased in venous compliance. So if I decrease venous compliance or I increase my blood volume, what happens to this curve right here? Or what would happen, do you think, which one of these? The cardiac output curve, or the venous return curve? Which one's going to change? Well, obviously, it will be the venous return curve, but would it shift to the right, to the left, down, or up? Well, it's going to be a little bit more up, and it's going to shift out this way, just like so. That is a decrease in venous compliance or an increase in blood volume, okay? So restated, that is changes when you have an increased blood volume or a decreased venous compliance. The venous return curve shifts to the right in a parallel fashion. So what would that mean about cardiac output? If I asked you, when you have an increased blood volume, what happens to cardiac output? Obviously, cardiac output would be increased, right? So if cardiac output is increased with an increased blood volume or a decreased venous compliance, what happens to right atrial pressure? Well, it was here, now it's here. So right atrial pressure is increased. Right atrial pressure increases along with cardiac output, because it was here, now it is there. So that's what you see with an increased blood volume or a decreased venous compliance. So what happens, what type of changes do you see when you decrease blood volume or increase venous compliance? Well, obviously, in a parallel fashion, the venous return curve will shift to the left, and cardiac output and right atrial pressure
would be decreased because it was here, now it's there. It was here, now it's there. That simple. So if you were to get cut with a knife and you're bleeding profusely, obviously this right here will now be your graph and your intersection will be right there. If you were to get transfused with a huge bolus of saline, obviously this would be your graft, right? Here would be your intersection. So it's literally that simple. There's no reason to miss it. But let's talk about what happens or what type of changes you see if we were to add an inotropic agent. So let's get this off of there. Okay. So, and instead of my drawing, here is a better illustration. Or yeah, that would actually be if you were to add a positive ionotropic agent. Right here is what you would see. Positive ionotropy shifts the cardiac output curve higher with correspondingly lower right atrial pressure and a higher equilibrium point. There's your new equilibrium point. So you have a lower right atrial pressure and a higher equilibrium point, and it's just shifting your cardiac output curve higher. So what about a negative ionotropic agent? Well, it's going to shift the cardiac output curve lower and with a correspondingly higher right atrial pressure at a lower equilibrium point. Looks something like that. Here will be your new intersection point. So that would be a negative ionotropic effect. Okay, so what about changes in TPR or total peripheral resistance? Okay, this is the one that throws a lot of people. So when we start changing the total peripheral resistance or TPR, first of all, it's determined by the arteriole's resistance. And this will change the slope of not just the cardiac function curve, but also the venous return curve. So it changes both slopes. And that is what people miss. It's what I missed when I learned it. So if you increase the total peripheral resistance, it causes a decrease in both cardiac output and the venous return curve. So what does that look like? It looks like this. So you get a counterclockwise rotation of the venous return curve. If you look at that kind of, what does that mean in layman's terms? It means blood is retained on the arterial side, okay? So what about the cardiac output curve? Well, you're going to get a downward shift. You get a downward shift of the cardiac output curve right there. That's all that means. Now, what would, in terms of circulating blood, if I decrease the total peripheral resistance, that results in what? That results in more blood volume staying on the venous side of circulation. It's literally that simple. So that would mean the slope of both, remember, because we're affecting both here when we talk about total peripheral resistance, the slope of both the cardiac output and the venous return curves increases. So it gets more vertical. So you're going to be here, right? That's going to be your intersection. And that means that both the cardiac output and the venous return increases for any given right atrial pressure. All right. But now, right atrial pressure, here's the catch. When you increase it, right atrial pressure, and this is one they like to test you on, remains what? The same. Don't miss that. Right atrial pressure in all these, because remember, that's what we're talking about here, in diastolic volume or right atrial pressure, it remains the same. Tested over and over and over. So if you just keep those simple concepts right there, you won't miss these questions, because it's a shame to miss them once you actually understand them. They're quite easy. So don't take this lightly, but just learn it on this basic of a level, and no matter what they ask you, just, am I shifting to the right, to the left, what's going on, am I losing blood, am I not, and you'll get these right. Okay, ejection fraction, or EF. What is that? It is exactly what it sounds like, the fraction of blood ejected from the heart during systole. So what is your normal ejection fraction? Normal ejection fraction equals greater than 55%. Don't forget that. Now, what's the equation for ejection fraction, which you do have to know? You don't have to know many, but you do have to know this one. Equals stroke volume divided by end diastolic volume. Or another way of saying that is end diastolic volume minus end systolic volume divided by end diastolic volume. Okay? Now, since stroke volume, what is stroke volume then? Since stroke volume equals end diastolic volume minus end systolic volume, you can correspondingly get these equations. So, just remember these, and obviously that one. Now, what would happen to the ejection fraction? This is how they're going to ask you this. If you had, let's say, I don't know, how about aortic regurgitation? What would your ejection fraction be? Well, obviously, you would have a high ejection fraction, right? Because you've got regurgitation into the aorta, right? How about if you had, let's say, a good one they like to ask you about, probably the most one, congestive heart failure. Well, congestive heart failure, a pressure or a volume problem. It's a volume problem, right? You don't have same compliance of the ventricle, or you lost your compliance of the ventricle, so you have a low ejection fraction. And that's all really you need to know about ejection fraction. Okay, moving right along. The good old boy here, the EKG. I'm going to show you a way that somebody showed me to make this extremely simple for you. But there is a few things that we have to know before we can start talking about the EKG. All right, so first of all, you have to know that you have a normal sinus rhythm of, actually, let's get a new screen here. You have a normal sinus rhythm of what? 60 to 100 beats per minute. And this is the regular rate and rhythm. Regular rate and rhythm. All right, so what would a sinus arrhythmia? Keyword sinus means it's originating from the SA node, which is the pacemaker of the heart, right? If you didn't have that pacemaker or that SA node, which remember has automaticity, what would your heart be beating? Faster, the same, or lower? Your heart would be beating, if regular is 60 to 100, your heart would be beating like at 150 or some crazy number. It's this sinus rhythm that keeps your heart at a normal 60 to 100 beats per minute, which is crucial for life, right? Because blood has to fill, and if it were beating too fast, what we would get on the side of angina, of the Frank-Starling curve, and we would never get the blood to the tissues that it needs, and it would become ischemic. And why do we need blood to the tissues? For oxygen, right? Which is the final electron acceptor to make our ATP to power all these pumps in every cell of the body. So that is the big picture. All right, so a sinus arrhythmia means it's a normal variation. Why do I know it's normal? Because of the word sinus. Sinus arrhythmia is a normal variation in the heart rate with inspiration and expiration. Okay? Sinus arrhythmia. Normal variation in what? Heart rate with inspiration and expiration. What about a sinus bradycardia? That is less than 60 beats per minute, and it has a regular what? Is it a regular rate? No, it's a regular rhythm. How about a sinus tachy? Sinus tachycardia means it's greater than 100, because remember, 60, 100 is normal, greater than 100 beats per minute with a what kind of rhythm? Regular rhythm. With a regular rhythm. Okay, now that we got that, what is atrial fibrillation? This is what they mean when they say irregularly, irregular. Irregularly irregular what? It's an irregularly irregular QRS interval or intervals with no keyword, no discrete P waves. What is a P wave on EKG? And if you don't know, don't worry about it. We're going to talk about it here in a minute. P wave is atrial depolarization. So what's the problem? We'll have a little clinical correlate here. What is the problem with atrial fibrillation? It increases your risk of emboli from an arterial clot, since the left atrium is dilated and contracting asynchronicous. How do you say that word? Asynchronously. Yeah, that's right. Asynchronously. Now, why is that? A lot of people miss that. Or another way the boards like to ask you, and they could ask you this on even step 2, it's kind of a secondary, tertiary question. But atrial fib, man, if they ask you what's one of the most common causes of ischemic bowel, it could be AFib. A lot of times it is AFib because why? We threw a clot to the bowel and there you go, it becomes ischemic bowel disease. AFib, what happens is whenever blood is static, and it's not moving, it clots, right? So hence, therefore, you're in an increased risk of emboli from arterial clots. And this is why we worry about AFib and put people on warfarin. Okay, so what about atrial flutter? Atrial flutter. This is identical consecutive atrial depolarizations that result in a sawtooth appearance. Okay, now what do we got to talk about since we talked about that? Heart block. Heart block. We're going to look at these here in a minute, but let's just get the overall definitions. A first degree heart block. Let's get a new page here. First degree heart block is also another way of saying it is the atrioventricular block. This is a PR interval prolonged for the number you have to remember, greater than 200 milliseconds. Okay? What about a second degree heart block? This is you have two types here. You have a Mobitz type 1, which is also known as a Wenckebach, or a Mobitz type 2. These are you can say these as also an atrioventricular block, second degree AV block, Mobitz type 1 or Mobitz type 2. Mobitz type 1 is also known as Wenckebach. So, a type 1 Wenckebach is a progressive, keyword, progressive PR interval lengthening. And I'll show you pictures here in a minute until a beat is dropped. That's all you have to see, is it getting longer and longer. So it's a P wave followed by no QRS. Okay? Now, what is a Mobitz type 2? A Mobitz type 2, keyword, has normal PR intervals. Okay? But a coordinated QRS drop following a P wave. Okay, that's all it is. It's generally due to a block in what part of the heart? This one is usually, not always, but generally due to a block in the His-Purkinje fibers. Don't forget that. Or His-Purkinje system, I should say. Okay. Now, for what I mean is, for example, you can have they'll say something like you have a 3-2 block. Basically, what that means, whenever you hear that, don't be freaked out. It's just that you have 3 P waves with 2 QRSs. That's all that means. So a Mobitz type 2 is inherently unstable and can progress to what is known as a 3rd degree heart block. Now, when you hear 3rd degree heart block, that is what is known as a complete heart block, okay? Or a complete AV block. That is a 3rd degree heart block. That means that the atria and the ventricles beat independently of each other. Keyword independent beating of atria and ventricles. That is no bueno. And it's an unstable rhythm, okay? Unstable rhythm. Unstable rhythm, and it requires what? What do we do for 3rd degree heart blocks? Requires a pacemaker. Requires a pacemaker. All right, so now that we have talked about heart block, which we're going to see shortly, let's talk about VFib. We're just getting some general definitions here. Ventricular fibrillation, you need to know, has no identifiable waves since the what is completely erratic. Erratic rhythm. Okay? Has an erratic rhythm. No identifiable waves. This requires immediate defibrillation, right? Because we're fibrillating, we need to defibrillate them. So it requires immediate defibrillation with subsequent cardiopulmonary resuscitation. All right. Now that we've got those terms and definitions kind of down as very, very general, let's move on to an easier, I won't say, not easy, but a much more simplified way to read the EKGs. Okay? Now, we have a 12-lead EKG we're going to look at, but for right now, I want you to imagine that you have your AVR, your AVL, and your AVF leads. Okay? Now here's how you need to look at this. Imagine that this guy, as he runs from left to right, turns around and sees the heart. Actually, yeah, okay. Actually, disregard that. That's leads 1, 2, and 3. Imagine right here, this is how these leads see the heart. AVR can see it from this point of view. So he sees what? The right atria the best. AVL sees the left atria the best. And AVF is seeing the bottom part of both ventricles. But since the heart is kind of contorted this way in the chest, he's seeing the right ventricle the best. Okay? Moving right along, now we put leads 1, 2, and 3 along with this. So what do they see in the heart as? Now, here's the point of view where they see the heart that confuses some people. Imagine what I began to say a second ago. Imagine lead 1 is running from left to right. Then when he gets over here at AVL, he can turn around and he sees the heart with the same view as AVL. So leads 1 and AVL see the same thing. They both see the left atrium the best, okay? And they can somewhat see the left ventricle, but they see the left atrium the best. Now, leads 2 and 3 are both running down the sides of the heart. Leads 2 is seen, remember I said you have to get down here before it turns around and sees the heart. So you have to imagine it going out here past this diagram, and it can see what the best? Both of them see, like we said, the bottom part of the heart, but lead 2 sees the left ventricle better, whereas lead 3, imagine it coming on down here, it sees the right ventricle better. So lead 2, they both see the bottom, and 3 see the bottom part of the heart, but if you want to get specific, lead 2 sees the left ventricle, and lead 3 sees the right ventricle. Okay, very good. Now, here's those put together. So, leads AVR, he sees what? He sees the right atrium very well, just like that. Leads 1 and AVL, both see the same thing, left atrium. Leads AVF, leads 2 and 3, AVF, 2 and 3, all see the same thing. They see the bottom of the heart. That's simple. Both are all seeing right there. So when you look at lead 2, lead 3, and AVF, they're all showing you the bottom part of the heart. It's literally that simple. So now let's put some more leads on there. Let's put leads V1, V2, V3, V4, V5, and V6 on there. And literally they see right where they are placed. Lead V1 is seeing the right atrium. V2, you need to think sees the left atrium. V3, he's right here on the septum of the heart. Don't worry about him. He really doesn't tell you much. But look at this. Lead V4, V5, and V6 all see same thing. They pretty much tell you about what? The left ventricle. Very important part of the heart, which pumps the blood to the whole systemic circulation of the body. So when you see 4, 5, and 6, just think they're all telling you about the left ventricle. And we can see that here. See there? They all see the same thing. And then we will get into how does the heart depolarize, and that'll really help you understand EKGs.
So the membrane potential approaches potassium equilibrium once more. Now, what two ions besides potassium are responsible here? That's right, your sodium